So, on the surface, this should be an easy topic to discuss, But when you start to think about normal nose, that is, okay, how can we describe what a normal nose should look like? Probably if a patient should come to us and say, I feel normal, is that what we consider a normal nose? If we take a CT scan, it could be telling the physician, forget what the patient say, do your examination, look at the nasal passage, then decide if you feel this is normal or not, One other option could be, okay, give them some kind of survey, depending on their response, you decide what is normal, right? Oops, what's going on? Just press it on the left side. Yeah, then one other one is, okay, we all have some idea or perception of what we feel normality should be. Are we going to go by that description? Or probably it's all of the above, So when you do all of this stuff, then you now decide what a normal nose should look like. Okay, so when you finalize you have a normal nose, in my opinion, I consider some stuff confounding factors, What are the stuff that will confound your CFD results? Because somebody can be normal, but when doing CFD, we take a snapshot in time of their CT. So their CT scan is a snapshot in time. And that CT scan can look like this. We've talked about nasal cycling a lot, Guilherme and I, we've worked a lot, We know the issues of nasal cycling. This is one snapshot in time. This is the information you have to do your CFD analysis. Is this going to be a big confounder or not? It could also look like this, Should we worry about what the results should be? Okay. What we notice is that the prior two patients I showed, they were normal patients. So they were normal people with nasal cycling. I'm sorry. This is a case where we have a patient with rightward septal deviation. This is a symptomatic patient. We know that this patient has nasal airway obstruction, and the deviation is to the right. From our knowledge, when you have a deviation to an area, that region tends to be the more obstructed side. So when you do your CFD analysis, the obstructed side has a lower resistance, a lower flow, unilateral flow rate, right? However, from our CT, we have somebody with a right septal deviation, but that right side has to be the decongested side. So the obstructed side is decongested because of nasal cycling. So our knowledge of what CFD tells us is that the obstructed side should have a lower resistance. But with cycling, what you see is that the right side that should have, the right side that should have a higher resistance, with cycling, that right side has a lower resistance. So the side that should be good is actually looking like it's the bad side. This is the effect of cycling when dealing with, one snapshot in time. And that can be a confounder when looking at normal subjects. Okay, let's look at, degree of septal deviation, Among clinicians, they feel like if you look at the degree, if it's maybe more than 15 degrees away, it's symptomatic, This is a typical case of someone that has septal deviation that is symptomatic. In an ideal situation, we feel like we want to have this nice, patent, almost straight nose to work with. That is the kind of normal person we want to work with. Okay, what if we have two subjects? So we have two subjects. They look, in my opinion, they look almost identical. They have some degree of, septal deviation, Other than that, they look very identical. One of them say they are symptomatic. Can anyone guess who the symptomatic patient is? You have the right and the left. Maybe show of hand. Who thinks the right person is symptomatic? One. This is right. This is left. So who thinks the right is symptomatic? Only, okay, two people. Who think the left is symptomatic? More people feel. So again, this is right. This is left. Right? So this is what we found out. That is the symptomatic patient. The other person is normal.
I think that on the right because of the piriform aperture is too narrow.
Okay.
The left side is simply a skewed chimney, which works perfect.
The left side is a normal patient, you know.
In my opinion, it's not possible to decide what's better, because if you aren't able to see the internal valve, you aren't able to in my opinion, it's the most important area, and you are in an area, I think 2-3 centimeters back. I would like to see the CT examination, the coronal CT from the frontal part in the area of the internal nasal.
Right, so you are a typical clinician that says, I want to see the full picture. But actually, clinicians looked at these two patients. So I am not the one looking at one scan. So a clinicians looked at these two patients. Does that make sense? I'm showing you one slide, but yeah, so this was looked at. The patient collaborated the story. Does that make sense? Unfortunately, I cannot show you more information. But the goal here is that there are some confounding factors of what a normal nose should look like. Does that make sense? That is the ultimate goal. Now you have situations of nasal cycling and septal deviation. Of these two patients, one of them has symptoms of nasal airway obstruction, which we've looked at before. So I'm not going to go into more details. So that is the symptomatic person. This is asymptomatic. Now, I've worked in this area a while. And if you ask me, I would say this looks like the person that should be having symptoms. They say they're normal. Their results.
Narrow with the piriform aperture. As a surgeon, I really appreciate that.
Yeah.
You got a very small nasal cavity. You may be in trouble when of the flow rate.
Okay.
Measure effective resistance, and you know what you have to do before and after decongestion, and you have it.
Well, the goal is to capture their natural state. So we're not going to use any kind of decongestant, So, but yeah, keep going, The nasal vessel, we've done some stuff in this area, and what we notice is that there's some kind of variation in the nasal vestibule. And what you notice is that you have two normal, these are normal patients, they are just normal, they are healthy. You see a notch, where you have the arrow pointing, you see a notch, in the airspace. In a notch case, the standard looks very standard, okay, no problem. You have some other variation that looks like, oops, how do I go back? Okay. So you have some other variation that looks like, so these are different variations of notch. Again, these are all normal subjects, so that's what I'm dealing with, You have all of these variations. What happens, and the reason why this is important is that CFD is very objective. So the anatomy, it considers the anatomy when generating results. So that needs to be paid attention to. Okay, this is the same stuff. And we looked at the airflow streamlines, that's what we say, But I want you guys to pay attention to the NA. So NA is looking at the region from the nostril to the anterior, the most anterior part of the inferior turbinate. AC is looking at from that anterior portion of the inferior turbinate to the corona. Then NC looks at what we consider the entire nasal passage. So pay attention to those. What you notice is that at the NA, so when you choose just that region, the anterior region, which is the nasal vessel, there's a huge difference between the standard patients, people that standard, like they have what we expect to be a normal nasal vestibule. There's a huge significant difference in their resistance. When you move to AC, so which is the back, the posterior side, you see a switch. There's a switch in resistance now. The standard is higher, the notch is lower, and it's significant. When you look at everything, it's all measured up, and there's no significance. So what that tells me is that these people claim they're normal, physicians looked at them, feel they're normal. So depending on your anatomy, there's something that goes on between the anterior portion and the posterior portion. So for people with the notch, the posterior portion might be compensating for their anterior notch. That's why global resistance, there's no difference between these two groups of people. That's my conclusion. I might be wrong, but that's it. Again, when you look at the anterior, you see that the difference is significant, and standard is higher. So standard has a lower resistance than the notch, and it switches when you go to the middle region. Then global, no problem. I'm running out of time. So you also have another confounding that I'm not sure if this is a big problem, but these are my colleagues. These are my colleagues and I, racially, this is how we are classified in the United States. Classifications are different depending on where you are. In the US, this is how you classify this kind of people. So we did a study and we looked at, this is a small study. So my results are just based on a very small sample size. But that is why we need to gather our data together so we can do a larger study to see what's going on. We did a study, and that's what we see, looking at the surface area to volume ratio. Blacks tend to have a lower surface area to volume ratio. Then the Caucasians a little bit, higher. Then we looked at resistance, that was the distribution. Fine. So based on this stuff, and nasal index is another, confounding factor also. But based on this stuff, we decided to okay, for this talk, what should I consider to be the confounding factor I need to accept as a big problem, and those that I need to disregard. It was very hard to decide. I ended up at the top of my head, okay, what am I expecting? I want to expect someone that looks like this. The cycling is mid-cycle, no obvious, changes. The septum is almost straight. And when I do the simulation, I want to see this, and I don't want to see what's below. So those are my criteria for deciding what to report. Based on this, I decided to look at just one group, white people, no other ethnicity. And we have, 35 people, 12 males, 23 females. Their nose scores great. We have the demographic information, CT, and we did CFD. So this is what their nose distribution looks like. The males are a little bit, the distribution is more than females, but the median score, female 0, which is great, males 5, and no significant difference, which is good. age, they're just about the same, the distribution about the same, so great. Weight, the men tend to be more overweight or heavier, whatever you decide, but it was significant. Looking at the volume was significant. Surface area, significant. When you do the ratio, they're not significant. So I'm going fast, I'm out of time, you know. Actually, I included, you know, question and, yeah. So now looking at unilateral airflow on the left side, this is great because the simulation was done at 15 liters per minute. So what you expect is that for normal subjects at 15 liters per minute, each side should be about 7.5, right? So for males, it's about 7.5. Great. Females, 7.4. It's the same ballpark. On the right side, the same stuff. So what I now did was, okay, let's look at the difference. So take each person, look at the difference, you know, in resistance. What we notice is that men tend to have a slightly more difference between the left and right side than females. In this case, the median is, you know, 4.7 liters per minute for men. Females, it's 2.3. But the difference was not significant. So that's great, you know. We looked at resistance, and females, a little bit, the median is a little bit higher and just a little elevated, but it wasn't significant, you know. Again, you know, the left side, right side, we looked at it. We are more interested in the difference because the difference looks at each individual. What's the difference in resistance? It was not significant. We ended up looking at the bilateral. So bilateral is combining both together. So all the other results were unilateral. But so combining both together, what we see that for normal patients, males and females, white, you know, no other ethnicity, white, there's some differences based on this small sample size. So that's what we have, and I have the wonderful opportunity to have collaborated, and I'm also collaborating with these folks, you know, and they've been very, very useful to me, and just, you know, having those conversations with them have been very good. Thank you very much.